Access, access, united we're strong. We won't go away because we know you're wrong. Access, access, you've had your way too long. We're here and we're gonna stay.
Hi, and welcome to Adapt Productions with CAN TV. I'm here today with Arnell Brady, a speech-language pathologist who works at a clinic in the Hyde Park neighborhood in Chicago. We're going to be having a conversation today about speech-language pathology and disability. First of all, welcome, and thank you very much for joining us today on the show.
Thank you, Gary.
To start off, why don't you just give a general overview of what is speech-language pathology?
Excellent question.
Thank you.
Speech-language pathology is basically the science and art of oral language. And the speech-language pathologist is responsible for the prevention, diagnosis, treatment, counseling of speech-language pathology or communication problems. Basically, it involves listening, speaking, reading, writing, thinking with language, voice, speech articulation, swallowing, and speech fluency.
I have a couple of people in my family who are speech therapists. Is that similar, or are we talking about kind of the same thing?
Well, speech therapist was one of our names. We've gone through an evolution of names, and speech therapist was one of the early names given to our profession. Speech therapist was given after we were basically called speech teachers.
Okay.
Then speech correctionists, then speech therapists, and then on to speech language pathologists.
Okay, all right, very good. Tell me a little bit about the clinic. How many people work there, and what kind of things do people do on a daily basis at the clinic?
When I came out of graduate school at Northwestern University, I came out with the idea that I wanted to hang out my shingle. I wanted to work in private practice. And there was a guy in Hyde Park who had a private practice. And so I went to work for him while I also did my clinical fellows year in a developmental Montessori school where I was working with multiply handicapped children. So private practice has always been something that I wanted to do. And after he got married, he sold me the practice for $600.
Quite a bargain.
Quite a bargain. Yeah. He sold me the practice for $600. And so I am a solo practitioner. I work alone. But while I was building my practice, I also worked 3 hospitals because I have a family and I had to support them.
Right.
So I worked the University of Chicago hospitals as a pediatric and adult neurology speech-language pathologist. I also worked St. Joseph's Hospital. I was chief of speech-language pathology, and I also worked Providence Hospital of Cook County, where I also was chief speech-language pathologist.
Okay, all right.
And all the while I was building my private practice.
Yeah. When did you know that speech-language pathology was your calling? What drew you to that profession, to that vocation?
What drew me, I took a class. I was going to be a speech teacher. I wanted to teach oral interpretation, drama, debate, and those sorts of things. And I took a class which was mandatory for speech teachers on speech correction. And a Franciscan priest was teaching the class, and he took the class on a visit to a speech lab. And when I saw that instrumentation, I knew that that's what I wanted to do.
Nice. Okay, great. And then let's go back to you and working at your clinic. Tell me again, like what does that look like on a day-to-day basis? Are you meeting with individuals and going through counseling or therapy, or going out and meeting with larger groups of people? Like on an average day, what does that look like for you?
Well, I'm a general practitioner, which simply means I service adults and children, pediatric and adults. My youngest patient has been 24 weeks post-conception, and that's when I was at the University of Chicago hospitals. I worked in the neonatal intensive care unit along with other departments within the hospital. And my oldest patient has been 102, in which I worked with in a nursing home. Both of those patients had swallowing problems,
okay.
Which we basically call oral dysphagia or swallowing difficulties. An average day at my clinic involves working with adults and children. I start at 7:30 in the morning, and I take my last patient at 7 in the evening. And I'm also open 6 days a week. So it's quite busy. I guess probably the most frequent type of case that we see is children in between the ages of 4 and about 16. And those children basically have language problems, problems in listening comprehension, problems in forming sentences or telling stories. Some people would call those children Pacific language impaired, where most of them have basically normal intelligence, but has an extremely difficult time learning language and learning how to use language appropriately. I also have some adults that I see who have things like mild cognitive impairments. Many of those adults are on medications for different sorts of conditions like high blood pressure or cancer treatments, status post-stroke patients who are on certain medications to kind of control things like their blood pressure, and patients who have diabetes. A lot of those conditions affect how the language functions, how your memory functions, and so we also treat those patients. So my day could go from seeing a 2-year-old child with Down syndrome to a 68-year-old adult with mild cognitive impairments and everything in between.
Yeah. Well, it sounds like you've got a very long day and a very interesting and diverse day on a daily and weekly basis. So, I mean, I can't speak for everyone in the general population, but when I picture in my head speech language pathology or speech therapy, I have certain images in my mind, but you being kind of able to mold and build your own private practice, I'm sure you're able to bring in innovative strategies of your own that you found that have worked. And I noticed you brought some things along with you, and some things are some things that I would never have expected to see at the office or the clinic of a speech language pathologist. Can you share a little bit? I think you brought a drum with you today.
Sure. I brought a drum with me. In 1994, I attended a brain symposium in Arlington, Virginia, put on by the 0 to 3 consortium. And those neuroscientists from all over the country were talking about the brain. I think was the 1990s was declared the decade of the brain. And they were talking about the different parts of the brain. They were talking about the different functions of the brain. And it kind of really sparked my interest in this brain and how the brain is responsible for all of our behaviors. And when I think about language behaviors and shaping language behaviors, trying to develop language behaviors, or even trying to maintain language behaviors, I thought about this brain, which is the mechanism that produces these behaviors. And I said, well, how can we improve the mechanism that produces the behaviors? Because we saw that a lot of times in traditional speech language pathology, people would be in therapy for years just trying to establish some very basic behaviors. And so I said that, well, if we focus on improving the brain, maybe people could learn those behaviors a lot quicker. Well, in studying the brain and the relationship that it had to some of our interventions, I discovered that the brain has basically 4 major learning features. And one of those features is that the brain is very good at detecting patterns or frequencies. And what is more instrumental in producing frequencies than the brain.
Right.
And so it really captures one's attention because it almost like overrides what we might call what we expect. And because the brain is a pattern detector, it focuses right in on those patterns. When I was at the University of Chicago in the neonatal intensive care unit, I noticed that on some of these very fragile, preterm and sick, in many cases infants, who could really had very little energy for movement, but they needed to move to get the circulation and the blood going. And so the neonatologists would put checkerboards on top of the isolette that they were in, because the brain is a pattern detector, and a checkerboard is a pattern, and it would cause the head to move like this. So it was getting movement, that normally we could not get. And so I said, well, in the same case, what about drums? And so I started using drums in my clinic.
Yeah.
And the first thing I noticed, especially some of my children who are on the autism spectrum, really took to the different frequencies that we could produce with the drum. And what that got for me was their attention.
Oh, yeah.
And so now we have a shared focus. And the focus is, and then the next beat would be to get them to imitate those beats that they were hearing.
Right.
And so the drums are still very instrumental, and I have, I guess, all size drums in my clinic, and several drums that produce very different sounds. And so the drums have always been instrumental, but the drums is one thing, and we also go to, I think I got it down here somewhere, the iPad.
Oh, right.
Yeah, that we also use in the clinic. The iPad, as the computer as well, has really revolutionized some of our intervention materials. We're dealing with this generation, which we basically, some people call the screen generation or the information generation. I'm a part of the traditionalist generation, born slightly before the baby boomers.
Mm-hmm.
But in using these types of instruments, we have found that not only does it capture the attention, but it also allows the participant to be able to engage themselves and involve themselves.
Right.
Just the simple act of pointing and touching, gives the person a much greater involvement in the therapy process than traditionally we would sit with picture cards and we would say, what is this and what is that? That does not give the person much involvement.
Right.
They're simply following your lead. But when they can begin to participate in things like the iPad, to where they can begin to follow patterns, follow sequences, create stories and things of that nature, they have a much greater participation and involvement. And what does that do for the brain? It takes the brain to another level of activity instead of just passively waiting for something to stimulate them. Now they have to control their attention. And that's basically what we're looking for. We're looking for not just stimulated attention where they just respond or react to a stimulus, but to where they now have to control their attention.
Right.
And basically it's shaping their cognition, shaping their knowledge.
Right.
And it's helping to develop motor patterns and motor control as well. The children just love this, and because basically what we want to do is we want to establish intention to attend.
Right.
We want them to begin to share our focus so we can begin to model for them the behaviors that we basically want to develop.
So what would be the next step though? Like there you have an exercise where you're moving shapes. But if we're talking about speech language pathology, what's the step between, doing
shapes
something with, using my hands and then going into the speech patterns and things?
Good. Excellent question. Because the next thing, that once we establish the attention, then we can begin to model speech behaviors that we would want. A lot of these types of things are there for the reinforcement. And we are trying to establish a reciprocal situation with the person. In other words, I give you something, you give me something back.
Okay.
The very rudiments of a conversation. I say something, you say something back, and then we maintain and carry on that conversation. Right. It's the same thing in words. Words are made up of sounds, and so I can begin to establish sound production leading into the blending of sounds, into the creation of words, and then into the creation of phrases and sentences.
Right.
Yeah. So that's kind of how all of that ties in. What you're trying to do is you're trying to share focus. You're trying to get the person to intend to do something, to be able to predict the outcome of a situation.
Got it. Okay.
And now the iPad is one step, but we've gone even one step further. And that one step further is where now we can begin to very safely and very easily measure brainwave activity. And the neuroscientists, thank God for the neuroscientists, they have shown us how certain brain waves are correlated very strongly with certain behaviors, speech behavior, reading comprehension, speech fluency, things of that nature. And so we can train a person how to control their brain waves, and we use that with an electroencephalograph. And basically this is what this is, a very portable device in which we can simply put it on the head of the person and clip this little ground to the ear. And on the computer monitor we have different activities, and we can measure the brain waves that are going on during those activities, and we can guide the person into the control of those brain waves, increasing speech fluency, increasing reading comprehension, increasing attention. And I thought it was very interesting that I think one of the Japanese electrical manufacturers at the last Consumer Electronics Show that I think they had in California had took the same device and was using it as a TV remote control, to where you could begin to turn your TV off and on and change the channels with your brain waves. And we found that devices and things, interventions of that nature, are able to replace things like medication in terms of establishing attention, in terms of shaping certain behaviors and concentration and focus.
Wow. I really love how you have the whole spectrum of kind of devices to work with, from the drum to the iPad to
the NeuroSky.
Right. You're really using everything that's out there that's available. I want to go back to something you said earlier. You said you're talking about the range of people who you work with. You know, a 102-year-old, as well as I think you said a 24-month-old or even younger.
Yeah,
How? For
a
that,
24-week-old.
24-week-old, even younger. I'm just assuming here, but I'm guessing that in order, you know, that infant, newborn, probably had a lot of good services where they were able to detect something that you know that needed attention in terms of speech at a very young age. But not everyone is going to have that type of support system around them, and I'm sure you've seen cases where maybe people go for years and years. Maybe they should have received attention, but they haven't. If someone doesn't have that mechanism where they can be identified as someone like, okay, you need to go see a speech language pathologist, what can someone do? Or do you see that as a problem in Chicago in terms of people not getting the speech therapy services that they need, and what can be done to make sure we're reaching more people?
Gary, not only is that a problem in Chicago, it's a problem in the nation. I remember some years ago when Ron Page was the Secretary of Education, and he said, America has spent $125 billion on special education, and we have gotten nothing for our money. And one of the great tragedies in America today is America's lack of signing on to the World Disabilities Act. The cost of mistreatment, the cost of the lack of treatment is astronomical. The lack of embracing some of the new interventions, because there might be an initial huge cost overlay in the beginning, is very detrimental and is very costly to our economy. I think disabilities in this country is running somewhere in the neighborhood of $180 billion a year. We know that cost could be greatly reduced if we could get legislators, if we could get educational administrators to loosen up a little bit. And because we've seen in this country the lack of continuing education. You know, many of the professions have had to very forcibly bring about continuing education in order for professionals to maintain their professional status. Now, what does that say about professionals? You know, once they graduate from their graduate school programs, in about 2 years, their knowledge is obsolete. But many of them were not going back, continuing their education so that they could stay abreast of what's going on in their fields. And we see just let's take a simple speech case. We know that to receive public school speech language pathology services generally runs about $400 an hour.
Okay.
All right? And a student say, let's come in with childhood apraxia of speech, which generally has taken about 10 years to establish functional speech. So you got 10 years of $400 and something an hour.
Mm-hmm.
We have a device now called Complete Speech, which is a pseudo palate that we can actually put into the child's mouth, and they can watch their tongue contact on the computer screen and be in and out of speech therapy with functional speech in 2 years.
Okay.
Put that child in a private clinic and say at a rate of $140 an hour and out in 2 years. Look what society would save in terms of money.
Right.
But because the clinicians won't go back and educate themselves on what is new, will bring about change in their systems, they continue to go down the same path, and the cost just increases every year. And that same person that they have tried to help to develop more so they could reach their full potential now has been marginalized, goes out into society, many cases does not become a productive member of society.
Right.
In many cases become dependent
Right.
upon society.
So it sounds like what I hear you saying is like what we need to do is kind of step back, take a look, and make some innovative investments that might cost more money today, but in the long run is going to save money and is going to better equip people to be productive, to be integrated, and contribute and participate. This might be related, but I Adapt Productions, I mean, we're a part of the disability rights movement in Chicago. We're working to open up more accommodations, make society more accessible, and kind of confront barriers. And one of the barriers that I mean, this still exists today, several decades after the Americans with Disabilities Act, is there's still a lot of stigma around disability. People with disabilities are treated differently, and as a result, sometimes people might not want to come out as a person with a disability. Do you see that in your work in any way?
Oh, definitely. Yeah. I've seen it break up homes, break up marriages. I've seen the confusion that exists around certain conditions like stuttering. People think that it's some sort of mental condition. I've seen around the autism spectrum disorders where they're still calling it a mental disorder. Sometimes in different voice problems, people think it's some sort of psychosis while the person is talking like that. I think people are very slow to accept things that are different, which I think is really unfortunate, because what we have seen is so much human waste in people not being able to accept differences, not being able to accept change. We see it in our language cases, in our reading cases, to where people, because they can't read, they're called ignorant, or they're called dumb, or they're called stupid, when we have interventions that can easily establish adequate reading. But because our systems are so slow in changing, we have seen states rewrite the educational laws to avoid certain types of conditions.
Right.
We have seen here in Illinois where they have rewritten the educational rules and procedures to not have to deal with speech and language issues. They'll want to call it special learning disabilities or things of that nature, so it's a lot less to treat in the short run, but much more expensive in the long run. We've seen them limit the involvement of speech language pathologists in the educational system because there is a critical shortage of speech language pathologists. But instead of steering people towards the field, they continue to sweep speech language problems underneath the rug. And we see in a place like Chicago, where in the African American community, where we still see 50% of the African American males are roughly not graduating from high school. And it was said a long time ago, what is the problem? What is the problem? They want to say gang violence, drugs, unemployment. That's not the problem. The problem was pointed out years ago, it's an inability to relate to the curriculum material. That's a language problem. Instead of calling in the language experts, they'll call in more police. They'll call in more disciplinarians.
Not taking a holistic approach.
Not taking
to
a
the
holistic
issue,
approach to the
So
issue.
we're coming close on time here, but I want to just kind of open it up for you. Maybe last question here. Like, where do you see in the future, 5 to 10 years? Like, what would you like to see in your field?
I really would like to see speech language pathologists involved in a lot more, because our economy now is based upon a communication model. Our employment system is based upon communication. We need good communicators. Good communicators. See, not only does the speech language pathologist work with people who might have difficulty in learning how to communicate, but we also work very closely with people who you might consider normal. There is so much improvement in the human brain in terms of its ability to be a better communicator. You know, probably the reason for a lot of the problems that we have socially is because we refuse to really grow in terms of our understanding. We refuse to grow beyond the basic knowledge that we use to feed ourselves and clothe ourselves. You know, the differences between the different social groups is basically a problem of communication.
Yeah.
So I would like to see the speech language pathologists involved a lot more in normal issues in terms of communication.
Right.
Because we have the science, because we have the art. You know, we're facing 80 million Americans, the baby boomer generation, who are now in 65 and around that age. What we see in that population is a lot of early signs of dementia. We see early signs of memory problems. We need to be involved with those memory problems because we can.
Right. Stop treating it as a separate issue and integrate it into, again, a holistic approach. Bring it all together.
Just like we have involved physical exercise in our everyday lives, we need to also involve brain exercise in our everyday lives.
Well, Mr. Brady, I really appreciate your time here. We've got to wrap it up, but I thank you so much for your time. I really learned a lot today. And I want to thank you all for joining us. This has been ADAPT Productions with Mr. Arnell Brady, and I hope everyone has a great day.
I want choices and right. Choices and right. Choices and rights in my life. I don't want your charity or you to be paid to care for me. I want choices and rights in my life. And I don't want to be in your care or to be put someplace out there. I want choices and rights